Welcome to Cancer Explained with Central Care Cancer Center. It's likely that someone you know has been diagnosed with a form of cancer. Learn more about specific cancers, their risks, signs, symptoms, and treatment options by listening to Cancer Explained.
Hello and welcome to Cancer Explained with Central Care Cancer Center. My name is Leanne Powers. I'm the Marketing Director for Central Care, and with me today is Radiation Oncologist Dr. Perez-Tamayo. At Central Care Cancer Center, we are dedicated to keeping expert cancer care close to home. We have state-of-the-art facilities throughout rural Kansas and in Missouri. Whether you need radiation, chemotherapy, a second opinion, access to clinical trials, financial counseling, or other supportive services for yourself or your family, Central Care Cancer Center is here for you. At any time, feel free to email with any questions or comments to askdoctor@cccancer.com. That's ask doctor@cccancer.com. March is National Colorectal Cancer Awareness Month. So today, our discussion on Cancer Explained centers around colorectal cancer as well as anal cancer. So first off, doctor, do we want to talk anatomy of the colon and rectum and how it all begins?
Let's do that. It is a very common cancer. It's one of the top 5, in fact, 3rd in the country. And unfortunately, 20% of the people that come in with colorectal cancer come in already with spread onto organs, liver, lung, etc. And this is an unfortunate situation, not that it can't be completely eradicated as a stage 4 cancer and be picked up early, but I think you need to be aware of symptoms and signs early on so that you don't have the situation where it gets out of hand. So anatomy is very important. Most of the cancers are divided into either the left side or the right side. And you may think, well, what does that mean? Well, the rectal cancers, which are the cancers that are within about 10 to 15 centimeters from the anus, are considered rectal, and they are treated in a very different manner than those that are beyond the rectum, which is the entire other part of the colon. That includes the sigmoid, which, and let's just go from the beginning. We have the anus, which is a different topic altogether. We'll touch up at a later time. Then we have the rectum, which is a rectal ampulla, which is the whole anatomy of it is to store basically the last parts of the stool so you can get the water out of there. And then you have the sigmoid, and it's like an S, that's why it's called the sigmoid. Then up, as we're going up towards the diaphragm, we have the colon that goes all the way to a little kink, which is a splenic flexure. Then we have the transverse colon, and then we come down all the way to the cecum, which is a pocket where the appendix is. And that's where the small bowel attaches to the large colon. The large colon is the last part of your intestines, which make you basically compact the fiber or any kind of residual from your food and extract whatever last bits of water or other nutrients that you could possibly use. So again, the right-sided colon is a very large part of your colon, yet it is not the largest part of the colon cancers. And most cancers actually are rectal cancers, and they're palpable with the examining finger. And in addition, thank goodness, they have a big voice when it comes to symptoms because you have bleeding, you have pain, you have change in bowel habits. Much less common are symptoms when you have something, for instance, in the cecum. Cecum is basically a cul-de-sac, or like if you could imagine a street with a court, like you live in, Richmond Court. It's circular, and you can get a big cancer there and you wouldn't know really what happened. While in the rectum, even though it is very flexible and it can expand to accommodate a big cancer, it does tell you early on that there's something wrong.
So since there is so much really to cover with the large intestine and the colon and rectum, you can have cancer at any point throughout any of the colon, correct? It's not
that
just
is right.
Pick a side or anything. It's
No, but it mostly is in the rectum again. So why, we'll talk about the right-sided colon, but since most of the colon cancers are rectal cancers, we can then discuss things that are particular to that particular area. And we can discuss others as well, but it's treated very differently because it is below what we call the coelomic cavity or the peritoneum. So what happens is, if you can imagine your abdomen being covered by baggie, let's say, or a balloon, and at the very neck of the balloon starts the rectum. So everything inside the big balloon is sealed by this baggie, while the rectum is not sealed by the baggie. So again, how it likes to spread and how you treat it is differently, because the patterns of failure for each of these areas is very different.
How long does it take usually, like, for polyps to grow or to start? I mean, is it a long process before?
It can be many, many years, but it can also be very fast depending on the type of polyp you have. There are some polyps which are premalignant and that need to be taken out as if they were cancer. And there's some polyps that just need to be removed, and if they are bland in their pathology, that should be enough. Now, there are some genetic situations where you need to, in fact, remove your colon if necessary to not go into a cancer type of scenario. There are genetics that are involved in these families with genetic predisposition to cancer of the colon. And you know you have that because you have people in your family that have been dying of cancer of the colon when they're young. And we're young, I'm talking about in their 40s or even younger. And they're syndromes of all sorts, and I won't name them all, but you know that, brother had it, your sister had it, your mother, your dad, your grandparents. And if that is the case, that is a different topic. And these types of cancers are dealt with differently, and you have to go to a high-risk colon clinic where they will do first genetic testing, and they will tell you what your risks are depending on what kind of situation you have. Now, if, for instance, your brother tells you, my last colonoscopy, you had 3 and 4 polyps, or they were serraceous in nature, for instance, then you need to be alert that could be you as well, and you need to then submit to a colonoscopy early rather than later. The typical recommendations are that you should give yourself a birthday present at 15 years of age, at 50, and that is your first colonoscopy. But if you have a family history of colon cancer, it may be earlier, in fact, even in your 20s and 30s. Now, please remember that colonoscopies are very benign. They are really quite easy on your body.
I was just going to say, I mean, it's not the best birthday present that I think most people want to give themselves. And they come in, I think, dreading having to get the colonoscopy. But
that's unfortunate because, frankly, you don't know even what happened. The type of medications that are available now, we call it conscious sedation. It's, as many people will tell you that do these, I'd rather go to a colonoscopy than have a dental appointment. So it is really quite easy. It causes you very little trouble. And actually, the worst part of a colonoscopy is that they wake you up. You're so asleep and you're so relaxed. You want to stay a little longer in that very relaxed state. But really, other than that, you don't have much trouble.
Early detection, again, is going to be key, and that is with the screening, both physical and biological exams too, right?
Yes, there are many things now that you may be a candidate for. Not everybody is a candidate for these. And certainly they are something you can turn in, a stool sample or a smear, we call it, and you can, in fact, ship it in the mail, and you will come up with the results. Now, not everybody is a candidate for this, and it's easier said than done. You have no idea how many people actually have the kit sitting in their bathrooms for months and months and years and never go ahead and do it. It is not complicated, but it is a chore. Really, if you are in your 50s in particular, and you're going to see your family doctor, your gynecologist, it is so easy to do a rectal exam, and they can do a smear of your stool to see if you have hidden blood, which could be a first sign of cancer of the colon. Now, if you have, for instance, black stools, not if you're eating a lot of beets and a lot of iron, you will have black stools because of that, or you're taking some green Kool-Aid or grape. But if you don't have any of these colorings due to what you're eating, and you have black, especially tarry, and tarry, what does that mean? Sticky stool. You need to report it to your doctor, because usually what that means is you're digesting a lot of blood from somewhere up in the colon or even the stomach that is being digested and is coming out as a tarry type of excrement. Now, if you have bright red blood in the stool, it could be as simple as a hemorrhoid. but let's check it out. And a rectal exam with your pelvic exam is recommended always. Why? Because not only do you feel all the rectum, but you also get to feel your ovaries and tubes and uterus, which you could not do with just a pelvic exam. So for the men, when they get their prostate exam, likewise, a rectal exam can serve also as a way of seeing what your rectum is doing. But your colon, that's a different story, meaning the balloon I shared with you above the neck of the balloon can only be seen with a colonoscopy, yet you can have symptoms that are just not quite right. You, for instance, have a normal stool mostly once a day, let's say in the morning, and all of a sudden you're having constipation and diarrhea at the same time, or your bowel movements change from 2 and 3-4 times a day or none at all. And this is something not due to eating a lot of cheese or other things that are maybe disrupting your digestion. It's better to check it out and be sure it's nothing.
Again, I'm with radiation oncologist and president of Central Care Cancer Center, Dr. Perez-Tamayo. March is National Colorectal Cancer Awareness Month, so we've been talking about colorectal cancer. Of course, you're always welcome to email your specific questions at askdoctor@cccancer.com. And doctor, one thing I wanted to ask you is if, for example, someone is not feeling well at all, so they go and they get their blood, tested to run just a normal blood test, and they see that maybe your red blood cell count is low and you might have anemia. That also could be some sort of a risk factor, correct? Because you are losing blood?
It's not a risk factor. It is actually a symptom. of somewhere in your colon or stomach area or even esophagus that you're losing blood very slowly. In fact, that is the most common presentation. And people, what do you have when you have a anemia due to blood loss? You feel tired. You feel short of breath. You may get palpitations of your heart. So see, all of these don't point to your colon, yet they are due to a colon problem because you're losing blood. And I can tell you in my own personal experience with my family that does come from a colon cancer situation, that has been the first symptoms of all the people, including my mother who had colon cancer. You begin to just fall asleep because you're tired. You may be in the restaurant and you order your food, and before the food is out, you're just wanting to go back home. So this is a very, very common complaint, yet it may be so subtle that you may think, oh, I'm working too much. I'm putting more hours in. It's too hot. All of these things that dismiss the symptom. Don't do that. It is a subtle symptom, but it is a very important one.
What about these risk factors then? I mean, I know we talked about, even family history, but is something as even having IBD or something, is that even a possibility of being a risk factor or not? Or Crohn's or
Yes, all
colitis?
of these things can lead to cancer of the colon because, and some things are not worked out. People think it's irritation. And with like Crohn's disease, there are syndromes that will put you at a high risk. Or for instance, people that have multiple endocrinological problems may put you at high risk, or something called the Lynch syndrome. What is that? Well, you begin to see that not only you have colon cancer in the family, but maybe you have other cancers, for instance, glioblastoma, multiple polyps, breast cancer, other things that put you in this higher risk situation. And now that we have blood tests that can tell you if you have a genetic mutation, then you are again go to a high-risk clinic. And it's such a simple thing to do. People, they don't do this very much, but they should. They should start chronologically putting in a family tree and seeing, what has happened, who has had cancer and at what age. And it could even be also stillborns. People don't count those. People that have had a lot of miscarriages, sometimes it's because the child has a mutation before they are born and they have a stillbirth or a miscarriage. So knowing these things, asking your grandmother, your mother, your aunts, all of these things, keeping in touch with this part of your family is important to you and to your descendants.
Stages. Let's talk about like stage 1 versus stage 3 or 4 with colon cancer as far as survival rates and stuff. Of course, if early detection and you can catch it early, your chances of survival are higher, correct?
Oh, there's no doubt. As I said at the beginning, 20% of the cancers of the colon present already at stage 4. Stage 4 meaning that they have already spread onto the most common sites, which include the lung, the liver, and the peritoneum. What is the peritoneum? What I said before, the coelomic cavity. So if you can imagine, again, this baggie that your bowels are in, it has basically shed seeds and it's floating around in the cavity. And there are some challenges due to that, and I'll go over that, why these are challenges for treatment. But the first stage that you want to see these in is called carcinoma in situ, meaning that it is still in the mucosa, very, very maybe irritated cells that are just beginning to become cancerous, and you can only pick those up with a colonoscopy. You have absolutely zero symptoms, or you have a high risk of colon cancer due to your family, and then they do surgery based on just your risks. Then we have T1 or stage 1, which is a cancer that just is invading the mucosa. And the mucosa is basically the lining of your colon, and it hasn't gone beyond that. Then we have a T2 cancer, which invades the first muscle layer of the colon. And from then you have cancers that are, for instance, T3, which go all the way to the serosa or the casing. Let's say the casing of, you can imagine, let's say a sausage. It involves the muscularis propria into the colorectal tissue outside. And then we have a T4 cancer, which is involving surrounding structures. And for instance, in the cecum or that cul-de-sac I talked to you about could be the liver, direct invasion into the liver, or it could be that it's involving the baggie, the peritoneum, or in the rectal case, it could be involving your prostate, your bladder, the uterus, the tubes, the ovaries, all the surrounding tissue. Then we have lymph nodes. And what are lymph nodes? And I've said this before in one of our talks. These are channels, these are connected channels into these stations or lymph nodes, which are supposed to identify things that are not supposed to be there. So if you had an infection, they would be swollen or, inflamed. But when it comes to cancer, they go into these ducts or channels. Imagine a train station the train going into the station or the node, and it doesn't know what it is, so it sends it to the next station. And these lymph nodes are very much involving the surrounding structure of the rectum, but they can also go into other surrounding areas that are usually anatomically described by the vessels that are affiliated with actually feeding that part of your colon. So for instance, if you have a very low cancer, let's say of the rectum, they can be feeding into the hemorrhoidal system or into the external iliac system or higher up into the internal iliac system, and these are vessels. These nodes then go all the way up to your neck if they would be that involved. So you want to avoid having a lymph node involved because that automatically puts you at a stage 3 category. And the difference between a stage 1, which is almost 100% survival, versus a stage 3, which, is about, if you're very lucky, and depending on how you respond, we're looking at 50% survival. It's a huge difference.
Yeah. Doctor, I also wanted to ask you about something I've heard some patients talk about when I've talked to some patients that have colorectal cancer is their CEA test, the tumor marker test. How reliable is that, and what is it really used for?
Well, the CEA and other tumor markers is not always reliable because not all tumors secrete this humoral substance, which is then picked up in the blood. A humoral substance, let's say it's a juice, and it then gives you a level of how active this cancer is. But not all cancers secrete it. So if you have it high, you can follow it and you can see if your cancer is active. Having this go down with your treatment and then go up is a bad sign. Now, if you have it and it doesn't go down with treatment, it's a bad sign. But if it goes down and stays down, it's a good sign. But not all cancers secrete it, and especially cancers that are more aggressive. Now, you can have a CEA or other of these humoral substances because you smoke, because you have other damage elsewhere, like in your liver, but they should be at a certain level, not at a level that is beyond what we consider, just a low level or a level consistent with, let's say, a smoker. So they can be useful, but really what is the most useful besides a rectal exam or a colonoscopy is the radiographic examinations to see if this has gone beyond the level of a certain treatment. And that includes, a CAT scan and a PET scan. They tell you different things. A CAT scan tells you about structure. For instance, are your lymph nodes involved because they are bigger? And a PET scan tells you if a normal lymph nodes, normal size, is there something inside them that is active and should not be there? We are now using more MRI for staging and for also treatment of colon cancer, especially the rectal cancers, because they tell us more about involvement of the fat. The fat in MRIs there's more affinity to seeing if it's invaded. And that tells us if it's a stage 1 or 2 or 3, or if there's lymph nodes involving in the fat. And that, again, would put you in certain categories of treatment.
I'm Leanne Powers with Dr. Perez-Tamayo from Central Care Cancer Center. We've been talking about colorectal cancer, but now, doctor, let's talk further about anal cancer. Is this fairly common, fairly rare, this type of cancer?
Actually, we're noticing that this is actually a much, much more common cancer than it used to be, perhaps because we're recognizing it earlier. But because of the HPV virus that has now become more prevalent, human papillomavirus is the number one reason why we have cancer of the rectum. Of the anus. Yeah. Actually, there's a very distinct difference between the pathology when you're looking under the microscope of what a rectal cancer is versus that of an anal cancer. I did not mention this before, but colon cancer is mostly an adenocarcinoma or a gland cancer from the mucous glands of your lining. This is a cancer that is distinctly of the skin of the anus. Now, there are people that divide it into what we call the transitional zone, meaning the cancer that is right between the anal cancer and the rectum, where one is an adenocarcinoma and one is a squamous, and they behave differently. Perhaps some people don't feel that way, and some are that is involving the anus proper, and one that is involving the skin around the anus. And so this is more akin to cervical cancer in many ways because it is a human papillomavirus type of cancer. And there are distinct activities which can cause you to have a higher risk of having an anal cancer. And the number one, of course, is having human papillomavirus. So if you have human papillomavirus in other places, for instance, the cervix, the vulva, the penis, the oral cavity, any part, you are at higher risk of having an anal cancer. Then we have other problems like smoking and anal cancer, and immunosuppression, meaning that for some other reason you are getting treated with immunologically suppressing drugs like a renal transplant, and you are just not able to control this infection because human papillomavirus is an infection of a virus, or another immunosuppression type of situation like HIV, and any organ transplant, any of these cancers that can be produced by viruses can go kind of wild. So if you are taking anything for rheumatoid arthritis or organ transplantation, anything that is suppressing, or you have an autoimmune disease, you are at higher risk.
Can anal cancer spread then to the rectum? Yes,
but it is not as common. Actually, anal cancer spreads locally. Yes, indeed, it can spread to the vagina if you're a woman and cause a fistula. What is that? Well, it's an abnormal connection between the surrounding structure, which is the lower vagina, or it can spread upwards into the rectum. It can spread around the skin. But the number one area where this likes to go is into the lymph nodes of the groin. So the lymph nodes of the groin, which are where if you can feel your pulse in your groin, those are the first lymph nodes, the femoral and inguinal lymph nodes, external iliac lymph nodes that are involved. In fact, they're involved so often that even if you don't have them positive by exam or by radiographic testing, we still treat them.
Okay, so tell me this. So as far as prevention for this would be like an HPV vaccination type of deal, or even condom use if it's a sexual activity
yes,
a possibility for
absolutely
contracting anal cancer?
Yeah. Yes, this is very common. And certainly protection is very, very key. And yes, the vaccination is very, very important for prevention of HPV infections and the consequences of them. But there is some more purists that feel that it is two distinct diseases, that of the cervix and that of the anal area. Nonetheless, they are highly curable, both of them. And so treating these that are very early in announcing their presence is important. Now, unfortunately, even though they have symptoms right away, they're usually misdiagnosed because people feel that you have either a venereal wart or you have hemorrhoids. This is the most common reason why people come in later than they should. And that is because they do go to the doctors. They do ask for something to be done about the pain or bleeding. This is a common symptom, and yet they find that they get nowhere. Now, this is why I always stress to people that if you're feeling that you're not getting the answers you want and you want to make sure, maybe get a second opinion. There's no reason why you can't. And even though you may not have been diagnosed with cancer, you can always go to a cancer center for a second opinion if you feel that there is something going on. Of course, the presence of a lymph node is always a worry. If you have a lymph node and meaning that you have a palpable mass that could be soft or hard in the groin, you need to seek attention, again, because you can get cured, even with lymph nodes. So you want to find this out early.
Is there a screening option then for anal cancer?
Unfortunately not. Unlike cancer of the cervix, there's no pap smear that is available as yet. And there is really just looking at it, you can tell it doesn't take a lot to look and say, wow, there's something going on here. And a biopsy of this is simple enough because it's very accessible. And you will find that 90% of them will have HPV positivity on the pathology exam. So once you have that established, then you go through a workup. And the workup not only will include, of course, the rectal exam and colonoscopy or analoscopy, then you'll have to find out what about the lymph nodes. And those lymph nodes can be identified with a CT scan and hopefully a PET scan. Again, the CAT scan tells us about abnormal size and shape of things, but the PET scan may tell us for a normal size or shaped lymph node, there is something going on that isn't right. But again, even if they're negative, these lymph nodes that are in the inguinal area are always going to be treated because they are highly at risk for being involved from the very start.
Doctor, is there anything you would like to add about colorectal cancer or anal cancer?
Yes, just remember that for anal cancer, you can still keep your anus, so let's keep it. So let's do the treatment, which is radiation and chemotherapy. Now, again, nothing is free in this world. When you have a cancer anywhere, and as in the rectum, which is a very flexible sphincter, you're going to get scar tissue, and you can get rigidity of this area. So the less of this organ to be involved, the more workable and more normal will you be your, follow-up and curability.
So, and also in conclusion, we should celebrate our birthdays and have our colonoscopy, and just for that screening option, just to be safe, catch it early. And treatment, of course, is so much better when you can catch it early versus later for colorectal cancer.
And remember that the rectal exam is great, but you need to spread those cheeks to let them see, because you can't see it with just your finger. You have to see it with your eyes.
I'm going to quote you too. Spread your cheeks. Thank you, Dr. Perez-Tamayo. Well, we appreciate you taking the time to listen to Cancer Explained with Central Care Cancer Center. With facilities throughout rural Kansas and in Missouri, Central Care Cancer Center offers complete cancer care all under one roof, so there's no need to travel far for the best care. Whether you need radiation or chemotherapy, access to clinical trials, financial counseling, or other supportive services for yourself or your family, maybe even just a second opinion, Central Care is here for you. You have a choice. Bringing expert care to you is an important component in the success of your outcome. In fact, being surrounded by your family and friends, that can be the factor that elevates your treatment. Feel free to reach out by calling 800-592-5110 or visit us online at cccancer.com. For Dr. Perez-Tamayo and all of our amazing providers and nurses, I'm Leanne Powers. Thank you for listening to Cancer Explained with Central Care Cancer Center.
You've been listening to Cancer Explained with Central Care Cancer Center, offering expert cancer care that's close to home. Central Care Cancer Center has clinics throughout Kansas and in Missouri. Central Care Cancer Center, online, cccancer.com.